Great. Hello, everyone. Welcome to the ANAC webinar. We're just waiting for everyone to sign on. We'll start in just a few seconds. I'm going to ask the presenters to please put themselves manually on mute until it's their time. Hello, everyone. We're just waiting for all the attendees to sign on. We'll start in just a few seconds. Okay. Welcome to today's webinar. This is the second in a series of webinar modules that we are presenting on PrEP, pre-exposure prophylaxis for HIV prevention. Today's module, Module 2, is HIV risk and prevention for Black men who have sex with men. I'm really thrilled today to welcome our two presenters, Dr. Sheldon Fields. Dr. Fields is a dean and professor in the School of Health Professions at New York Institute of Technology. Many of you who are on the line know Sheldon as a long-time ANAC member and former member of the board of directors of ANAC, so we are really thrilled to have one of our own presenting today. And joining Sheldon is Benton Jones. Benton is a real leader in HIV prevention and HIV justice. He is a program officer at the National Black Justice Coalition, and he will talk a little bit about his work in his organization and his section of the webinar. So you are eligible to get continuing nursing education credits upon the full completion of the webinar. You'll receive an email after the webinar with a link on how to complete the post test and receive your C&E credit. In terms of conflict of interest, Dr. Fields serves as a consultant to Gilead Sciences. Neither Benton Jones nor myself have any perceived or actual conflicts of interest related to this content. However, it is important to note that this program is part of a project supported through Gilead Sciences, awarded to ANAC. The learning objectives for today's session is, at the end of the session, participants will be able to discuss the current state of HIV risk for Black gay men, describe strategies and approaches to enhance PrEP uptake among Black gay men, and also to describe approaches to HIV education through a model program at historically Black colleges and universities. Just a reminder that everyone's lines are muted during the webinar, but we will have time at the end for questions and discussion, so I would encourage you to write into the panel on the sidebar your questions as they pop up, and we will respond to those at the end of the webinar. So please type in throughout this session any questions you may have. So here's our agenda. Quickly, we'll go over an overview of PrEP, remembering that this is one of a series, and we've done a series of PrEP webinars that provide a lot more basic information. I will direct you to our ANAC website to look at the content there. So we'll only have 5 minutes as a quick overview, then we'll really focus down in on some of the issues around providing PrEP and PrEP uptake for Black men. We'll also focus on innovative program at historically Black colleges and universities. We'll close with some PrEP resources, and then finally have time for questions and answers. So a quick overview. Again, I'll direct you to our website where you can look at previous PrEP webinars for more of an overview. But just to remind the audience that PrEP was approved for HIV prevention by the FDA in 2012. And really, the intent is that people who are vulnerable to HIV infection take PrEP or treatment-approved antiretroviral drugs to prevent HIV. Currently, there is only one drug approved for prevention, that's Truvada, which is tenofovir and FTC. This is delivered in a once-daily oral pill, the blue pill. There's lots of resources and evidence and information for clinicians that were released in the CDC clinical guidelines in 2014. Again, there's links to that on our website. And we know, and we covered in depth in previous webinars, that many clinical trials in different populations showed that PrEP was anywhere from 44 to 67% in reducing effective in reducing HIV acquisition overall, but with good drug levels. In other words, and you'll hear a lot about this today, when PrEP is taken, it's 92% or greater in reducing risk of HIV acquisition. And just a reminder, and again, there's lots more details on this in other presentations, that PrEP requires HIV negative confirmation prior to starting, and then ongoing HIV testing, as well as other lab monitoring, sexually transmitted infection assessments, and good adherence education throughout. So it's now my pleasure to turn the mic over to Dr. Sheldon Fields. Again, Dr. Fields is one of our own, an ANAC member, and the Dean and Professor at New York Institute of Technology. So Sheldon, are you there? It's yours now.
Thank you, Carol, and thank you all for joining us today. Greetings from Old Westbury, New York, in the School of Health Professions here at New York Institute of Technology. Really happy to be here to present the work that we've done on really how to increase the uptake of PrEP among Black MSM. You know, no matter what statistic you look at, from almost the very beginning of the epidemic, Black men who have sex with men have been disproportionately impacted by the epidemic. And I'm not going to inundate you with a bunch of statistics that you already know, but this latest statistic that was put out by, the CDC, basically talking about the lifetime risk of acquiring HIV is 1 in 2 for Black MSM. That really does underscore the need when you have a 50% lifetime risk in a vulnerable population. Talks to the need for pre-exposure prophylaxis among Black MSM. Next slide, Carol. So we are beyond the discussion about the efficacy of PrEP. All of the studies to date have proven that PrEP works in the various populations that it has been tested in. And we have proof of concept more specifically about its efficacy in MSM from the IPREC study. So this is just a chart that shows the various levels of effectiveness in the various PrEP trials that I know most of you are actually familiar with. And anywhere from a lower percentage of around 20-something, but we saw those in some of the early studies amongst women that had some other challenges. Not so in MSM populations. The studies have always proven that if taken, it does prevent. So next slide. So no matter how you conclude, there's been high levels of efficacy in MSM, transgender women, heterosexuals, and drug users. The key is adherence. It works if you take it. And very clearly, young MSM of color can clearly benefit. Across all of the studies, there's not been any serious safety problems. The issues related to creatinine clearance and the bone density all reverse once the medication is withdrawn. And if you get past the first couple of weeks of sort of the startup syndrome, the side effects usually does wane off. There was early on some discussion about if we put people on PrEP, everyone is going to, stop using condoms, and there's going to be a lot of, disinhibition, and it has really not proven to be the case. And these are populations that, quite honestly, more than likely weren't using condoms to begin with. So moving forward, even though we know that Black men who have sex with men can very much benefit from PrEP, compared to their white MSM counterparts, the uptake of PrEP amongst the population is less than ideal. The majority of those on PrEP across the country are white MSM. And there are some challenges to PrEP use amongst Black MSM. Listed here, long-term historical mistrust of our medical system, the cultural incompetence amongst some of the providers regarding Black MSM, still a lack of knowledge of PrEP amongst some Black MSM, and I'm so excited we have Mr. Jones who's going to talk about a project in which they're trying to make a difference in that realm. Lack of resources for PrEP payment, i.e. insurance, lack of accessible providers in some areas willing to prescribe PrEP, because ironically, some primary providers are just not willing to prescribe the medication. There's a good uptake amongst those who are willing to prescribe PrEP, who are advanced practice nurses and physician assistants compared to primary care physicians. And then there's PrEP stigma. There's the rise of shaming and people who are more sex positive being shamed for their use of PrEP, which quite honestly makes no sense when someone's trying to make a positive change to help benefit their health. But what we know, next slide, Carol, what we know is all of the studies to date, again, showed us that PrEP works, and it works if you take it. PrEP success has been tied to behavior, because the standard of care is still one pill every day, although the studies have shown that with some variation, you can probably get away with a little less of a daily dose, but the standard of care is still a daily dose. For Black MSM specifically, it is tied to the complexities of their lives that actually impact their behavior. We're talking about social determinants of health and the intersectionality of race, socioeconomic status, and sexuality, which has a synergistic effect on how Black MSM are able to uptake and adhere to PrEP. So what do we do about that? There was a need for a Black MSM-focused PrEP study. The IPREC study gave us proof of concept that PrEP could work in MSM populations, but quite frankly, it did not enroll enough Black MSM to make any definitive conclusions. We simply didn't know enough about how Black MSM would uptake PrEP, what was the best adherence methods for them. We did not know how could we best provide it, and we didn't understand all of the barriers. So what do? We got our own study. So this was HPTN 073, was the birth of a vanguard study that really tested for the first time pre-exposure prophylaxis initiation adherence among Black MSM in 3 U.S. cities. It was designed to recruit 225 HIV uninfected Black men who had sex with men using one-day oral Truvada, utilizing something called C4, a client-centered care coordination, which I'll talk a little bit more about. And once enrolled, we followed participants for 12 months, and it was done at 3 sites: Los Angeles, Washington, D.C., and Chapel Hill, North Carolina. So it was a vanguard study, and we knew that we had to do some things different because, quite honestly, doing the same thing the same way and expecting a different outcomes really is a definition of insanity. We did not do this as a randomized controlled trial purposefully, because randomizing somebody to receive nothing in the face of effective treatment is not something that we were going to sell to Black men who had sex with men. So we had to do some things differently in terms of how do we educate them, support them, engage them to support their choice of uptake in PrEP. So what do? We took a 4S bias approach, and we developed and utilized the C4 client-centered care coordination model. So one of the first things, yes, Carol, next slide. Going back to the 4S bias, this you have in front of you is the research team for 073. This was an HPTN first, a study team led by 4 self-identified Black MSM doing a study on Black MSM from design to completion. This is the first time this has happened in any of the networks, and I really want to thank Dr. Darrell Wheeler, Dr. LaRon Nelson, who was the lead C4 implementation scientist, and Dr. Leah Wilton, who was the lead behavioral scientist and is leading the qualitative part of the study. So this made a difference when we started talking to people in the subjects about their involvement in the study and their willingness to participate. So next slide. We branded 073 with the tagline, "My life, my health, my choice." Taking PrEP was not mandatory to be in the study. It was offered to all after an appropriate assessment, education, about the possibilities and the benefits of PrEP, and it was all about them making an informed choice to improve their health. What did we do? What was our outcomes? Next, the enrollment. We began the study in August of 2013. We were fully enrolled by September of 2014. Remember, the target was 225. We actually enrolled 226. And you can see the spread amongst the three sites. UCLA had the best everybody with one more participant. Given the epidemiology of the epidemic and the preponderance of infection amongst young MSM of color, we strive to recruit a significant number of the participants younger than 25. And as you can see, over 40% of the participants in this study were under 25. We concluded the final study visit in 2015. HPTN 073 has one of the highest retention rates of any HPTN study. The overall retention rate for participants was 92%. But how did we actually do with PrEP uptake? As you can see, over 79% overall PrEP acceptance. The median is some statistics about the population. The median numbers of male partners, as you can see, was 3 within 3 months, and 33% actually did report a primary partner, 73% were casual partners. Amongst those men who knew they had an HIV-positive primary partner, 96% of those men chose to uptake PrEP. It says that they knew what their risk was, and they chose to protect themselves. Among the men who reported casual partners or partners with unknown HIV status, we had an 86% uptake. And the adherence we measured by PBMCs out through the 52-week reaffirmed that the men not only took PrEP, but they took it consistently with 4 doses or more in a week. So we had good outcomes. So how did the C4 actually influence what we were doing? So client-centered care coordination is really an individualized prevention counseling sort of coordination model. What we did in terms of each visit, before we started talking about PrEP and them taking PrEP, we had a discussion with the individuals about the other things that was going on in their lives. Remember, we talked about that intersectionality. We knew that these men faced other challenges, and we could not begin to talk to them about PrEP without understanding how they were going to take PrEP in the context of their actual lives. It's that unique experience of Black MSM in the United States, even with regard to biomedical interventions, those psychosocial issues, and the barriers. The longitudinal management of clients self-identifying what their needs are, and it was developed through extensive literature review and years of actual clinical practice experience amongst the HPTN's Black Caucus, which is a very unique group within the HPN that really helped to develop the C4 model. So in terms of the theoretical framework, if we're going to talk about people's choice, the undergirding of it is self-determination theory. You have to give people choice in terms of the sociocultural factors that facilitate or even undermine a person's sense of volition and initiative. Part of the assumption is that humans have a tendency toward growing and mastering challenges and integrating those into a coherent sense of themselves. It's all about autonomy. Nobody was forced to do anything. It's a back and forth discussion. We engaged them about their target behaviors, when to initiate or not initiate, and you could initiate taking PrEP at any point in the study. Again, it was not immediately mandatory upon your enrollment. But with further implementation of C4, next slide. So all study participants were offered the once daily Truvada and combined with the C4 intervention. At every visit, you were given the opportunity to engage in a C4 visit as well as being offered to initiate PrEP if you had not initiated it at your visit before. Everybody was followed again for 12 months. And at each visit, we took the opportunity to also avail the men involved in the study with a list of local resources. And since we had 3 sites, each of the 3 sites developed a resource guide because of the geographical differences. There's a lot of case notes that were taken. Dr. Wilton is leading the qualitative assessment of the piece, which is going to give us some interesting data as to the men who actually, even after being educated, still chose not to take PrEP. But here are some of the outcomes between them. The differences amongst all of those enrolled, the majority had at least one C4 visit, as you can see. The average C4 visit was 29 minutes. There was those who were employed full-time and, of course, reported having sex with men had a higher predictive value of uptaking C4. And compared to those who actually declined taking PrEP, participants who initiated PrEP were more likely to utilize the C4 model. Here's a little bit more differences about the outcomes. Next slide. Of those who initiated PrEP, you can see, again, the majority at least had one C4 encounter. Compared to those who did not, you had a slightly less uptake of C4, and the average visit lengths in the C4 really didn't matter, but you can see at the bottom, those who initiated PrEP had more C4 sessions than those who did not utilize the C4, 6 compared to 4. So that is the major highlights of the HPTN 073. And I just wanted to take a moment, next slide, Carol. There are 2 other studies that are currently in the field. The HPTN 083 study is a phase 2B3 double-blind safety and efficacy study that's looking at injectable cabotegravir compared to daily Truvada for PrEP in HIV uninfected cisgender men and transgender women who have sex with men. And I'm on the protocol team for HPTN 083. The unique thing about HPTN 083 is being done both domestically in the United States and in several international sites. Of the target number of men being recruited domestically in 083, 50% of the domestic enrollment, about 950 men, must be Black MSM. It is in the protocol with an emphasis on also skewing it towards the younger demographic. The AMP study, which is a phase 2B study to evaluate the safety and efficacy of VRC03, the broadly neutralizing monoclonal antibodies, is also being conducted amongst men and transgender persons who have sex with men as well. And this study does not have set targets for the enrollment of Black MSM, but each site has been encouraged because this is a joint VTN and HPTN site, and they were given the same recommendations as to the need to over-enroll Black MSM. So, in conclusion, for my part here today, PrEP works if you adhere to it, that much we know. Black MSM still tend to underutilize PrEP in relation to their risk and their white counterparts. HPTN provided evidence that Black MSM, when given a choice, will initiate, uptake, and adhere to PrEP with culturally relevant support. That was the C4 intervention. The HPTN 083 and the AMP studies provide new opportunities for Black MSM to be involved in further biomedical research, testing the newer innovations in PrEP, and we encourage those men to enroll in those studies as well. I will end here by simply acknowledging all of the HPTN sponsors. You can see for yourself an extensive list of people involved. And on that note, I will turn it back over to Carol and to my colleague, Mr. Jones. Thank you for your attention.
Thank you, Sheldon, so much. I will say there are a number of questions that have come in through the chat box related to your presentation. So we do have time at the end for a lot of discussion there. And I will encourage other members of the audience to write in your questions into the chat box throughout the presentation. We already have 6, so I think we're off to a healthy start. Here's Sheldon's contact information if you want to talk with him directly, or we also will have ways to connect with all of us at the end. So it's now my pleasure to go on to the second part of our presentation, and that's really looking at an exemplar program. When we put this webinar together, we thought about shining a spotlight on some really innovative programming that's working. And we're thrilled to have Benton Jones share with us his work on HIV risk and prevention for Black men who have sex with men, a program called Prepping Our Futures that he is conducting at historically Black colleges and universities. And Benton joins us from the National Black Justice Coalition, and he'll talk a little bit about his organization as well. So Benton, are you there? Am I ready to turn the mic over to you?
I am, and I'm ready.
Hi, good. Okay. It's all yours.
Wonderful. Thank you so much, Carol, and thank you to ANAC for the invitation to present about our HBCU tour. My name is Benton Jones, of course, and I am from the National Black Justice Coalition. For some of you who may not be aware of the National Black Justice Coalition, we were established in 2003. We are a national civil rights and social justice organization dedicated to the empowerment of the Black LGBTQ same gender loving community. And a lot of our strategic advocacy focuses on the impact of federal public policy and its impact on the lives of Black LGBTQ same gender loving people. And so another premise of our organization is also our building stronger Black families with the emphasis on uplifting the needs of Black LGBTQ people. And I'll tell you a little bit about that later on in the presentation. All right, so the National Black Justice Coalition, part of my role as program officer for LGBTQ health and wellness initiatives was to help be a part of the team that launched our health and wellness initiative in 2014. And that initiative had the key goal of addressing health disparities that are of particular impact to the Black LGBTQ community, particularly the HIV/AIDS epidemic. And last year, we had the opportunity with funding from both the Elton John AIDS Foundation and Gilead Sciences to expand to our work and health and wellness work to include a HBCU tour, particularly focused on HBCUs in the South. Next slide. All right, and so our Prepping Our Futures tour focuses on a couple of things. One, increasing engagement to cultural competent activities to educate and improve HIV rates and other health outcomes for Black LGBTQ people. And so when you think about this cultural competency piece, a part of our work on HBCU campuses has been to really educate about the presence of the community, educate about the needs of the Black LGBT community, because for so long, a lot of their existence wasn't even acknowledged on these campuses. So really working to improve the competency of not only students, but also administrators, faculty, and other individuals that impact the community, including health providers, their competency to help to support the needs of the Black LGBTQ students on that campus. And so our efforts focused on building online media, direct community outreach, and also information exchange opportunities to outreach to 5 states in the District of Columbia, and that includes Florida, Georgia, Maryland, North Carolina, Texas, and Washington, D.C. To educate their student bodies and also educate health providers on those campuses who also needed information about PrEP as a tool to fight HIV. Next slide. And so on the right, you can see some of the schools that we started with last year, including Florida A&M University in Tallahassee, Florida, Spelman College in Atlanta, Georgia, Morehouse College in Atlanta, Georgia, Morgan State University in Baltimore, Maryland, North Carolina Central University in Durham, North Carolina, and the University of the District of Columbia. And since this, we actually needed to update this with our partnerships this year. We've added Prairie View A&M University in Prairie View, Texas, as well as Howard University in Washington, D.C. And so what we wanted to do specifically regarding PrEP, we had 3 key goals: increase exposure to PrEP and corresponding HIV messaging among the Black community, particularly among those who are young MSM and transgender women, by hosting HBCU campus engagement events. And this includes our cultural competency trainings that we did on the campus, that we do actually on each of the campuses, increasing partnerships promoting PrEP as part of comprehensive HIV prevention among the Black community, particularly MSM and transgender women. What research from the Williams Institute at UCLA states that Black LGBT people, for the most part, live, work, and play within the Black community. So really utilizing partners like HBCUs to allow access to be able to touch a larger nucleus of Black LGBT people is definitely important. But more importantly, being able to also increase the competency of those who engage with the community. So that includes school officials, that includes elected officials, that includes parents, and so many other areas that really touch the environment of the community. And so our third one was to mobilize a cohort of stakeholders from across the United States in order to increase PrEP and HIV advocacy, which that will lean towards our program that we will be launching as part of our HBCU tour in the fall, our PrEP ambassadors, where we are working with students on campuses, the campuses we have worked with in the past, to institute PrEP ambassadors to help increase peer-based engagement and information exchange for PrEP. And so starting this summer, we will have a intern from Morehouse College who will help bring that program online. Next slide. And so as we were developing the Health and Wellness Initiative and the HBCU tour, Dr. Fields talked about some key areas that we really had to tackle and deal with, and that's really intersectionality, really dealing with race, dealing with sexuality, also dealing with the other things that were going on in the lives of Black MSM. And so that did not just include HIV, that included dealing with racism, dealing with poverty, dealing with depression, dealing with all these issues, particularly for students, and being very aware that and conscious about in outreach efforts and education efforts that these issues were also something that was spoke to, compared to just a very static message of you're tested for HIV so you don't get HIV. Next slide. And here, as another example, we look at health disparities, particularly if you notice in the South where the concentration of where those disparities exist. And keeping up with the research from the Williams Institute of Black LGBT people living where Black people are, we notice that the concentration of Black people in the South and also overlaid with these different issues. And so really understanding that we had to also, in our efforts, to not only talk about different issues that were going on in the lives of Black gay men, but really also talking about at the same time other health disparities that had a concurrent impact to the community. Next slide. And so we developed a message that we wanted to take this information from the laboratory into the living room. And what we mean by that is, from a community perspective, how do we make sure that messaging about PrEP, about HIV testing, about STI treatment is delivered in a way that it can reach someone, the average person in their living room. And then on the other end, how do we make sure that healthcare providers, that researchers, and other advocates are speaking not only about the research as it relates to treatment and prevention efforts, but really talking about the other, the intersecting issues, as Dr. Phil said, like racism and homophobia and access to health care that also has to be addressed, and making sure that those things were actually coming down from the top and actually a part of solutions when going into communities to discuss HIV prevention and treatment. Next slide. And so part of our online outreach was to particularly increase messaging focused to the African American community on key HIV awareness days. World AIDS Day, the National Black HIV/AIDS Awareness Day, where the National Black Justice Coalition had the opportunity to host an event called the Summit on Black Lives, Black America's Response to the HIV/AIDS Epidemic, where we invited 50 policy experts as well as Black executive directors of HIV organizations to speak about and strategize around ways of addressing the HIV/AIDS epidemic from a policy perspective, from an outreach perspective, and really from a community mobilization perspective as well. And then also to the far right of the slide, you'll see for our message for National Women and Girls HIV/AIDS Awareness Day, where we really wanted to utilize messaging as well as utilize Black faces and the Black community taking action to address the HIV/AIDS epidemic. Next slide. And so part of our national engagement includes, here are a couple of pictures from one of our stops last year at Morehouse College, where we had the opportunity to conduct a 3-day training that was actually supported by the Vice President of Student Affairs as well as the President's Office. And so that allowed for faculty to be required to come in to participate in these trainings as a part of their Title IX compliance to ensure that discrimination is not occurring on campus. And so part of what we had an opportunity to do was educate the student body about PrEP and HIV prevention, as well as LGBTQ cultural competency, but also have the coaches, which you'll see towards the middle right of the screen, of each of the different athletic departments that also had to take part in these different trainings so that they can be aware of these issues, and also creating the environment for their student body to be able to have safe and supportive spaces for them to matriculate at the institution. And so we brought also to help facilitate these conversations the CDC, who came and who is a partner of ours at our different HBCU tour stops. Next slide. And so we had the opportunity to utilize some polling software called Poll Everywhere, where the individuals in the audience had the opportunity to participate in a live poll utilizing their cell phones. And so we asked them key questions that really gave us some key information about where people are as it relates to knowledge and engagement around PrEP and HIV testing. There's a lot of people, you know, just based off of the audience that we took, and this was at our Morehouse visit, where there was probably about 100 people in the audience. We asked these key questions, and so we knew that individuals knew about PrEP's existence, but what we found troubling is that as we asked the next question, how do you feel you have a professional on campus you can talk to about your healthcare needs, over 50% of those students in the audience said they do not have a professional that they can speak to about their needs. And so the question leaves, who's educating them about PrEP? How is messaging about their sexual health, about their overall health and wellness is being addressed if students are not feeling that they have professionals on campus that they can speak to about what's going on? And then our last question about HIV testing, where we see that a majority of the students in the room, and mind you, these are student leaders, these are RAs, these are fraternity presidents, sorority presidents, these are leaders from across the campus, and these are the answers from these bodies of leaders impacting the students every day. And almost 40% mentioned of not getting tested for HIV in over a year, and definitely seeing 40% uptake, 40% of testing within the last 3 months, but definitely seeing also that there was an issue with a significant body in the room around getting tested within the last year. Next slide. And so this is another stop of our HBCU tour stop this year at Prairie View A&M University, where we came together and worked with their LGBTQ organization to talk about the HIV/AIDS epidemic on their campus, particularly being a institution almost parallel with a high morbidity and mortality area of HIV, and that's Houston, Texas. And so what was key from this institution is that the students found it challenging around the polling question that we had in the last slide around talking with healthcare providers. This was a direct quote by one of the students. Unless you are pregnant or an athlete, you would have to usually wait 2 weeks to see a doctor for anything. And in this community, the nearest hospital facility is 20 miles away. And if you needed more significant care, you would have to drive almost an hour away to Houston, Texas to get any additional care. So what does this mean when there's an urgent response needed to address outbreaks of STDs on these campuses? We see that the students do not feel comfortable in engaging health services to get that care. And then also making sure that the work is also done to educate healthcare providers about the unique needs of its LGBTQ population and acknowledge its presence on its campus and start working to make sure that issues are addressed within that community of the campus. Next slide. And so these are just examples of some of the materials that we use in our outreach on the ground, and particularly as it relates to health services, what we noticed that materials in those student centers were not culturally competent in the particular area of imagery for the students to pick up. What we noticed students saying about materials is that they wanted to see images of themselves. They wanted to have images and experiences that were talked about that relates to their everyday life. And so part of our efforts were to work through another project that we have in partnership with the CDC as a partner with their Act Against AIDS initiative to help create HIV messaging that speaks to a broad base of the African American community, and also that speaks to specifically speaking to the needs of Black gay men and also Black transgender women, and creating those safe spaces for parents, for support networks, and for friend networks to be able to help transmit positive messaging about health and wellness, particularly about HIV prevention, and also increasing knowledge about the existence and availability of PrEP. Because what we are seeing on the different campuses, while a lot of people may know about PrEP, there are a lot of questions around access to PrEP, and on the different campuses, not having access to PrEP at all. Part of our work at Morehouse College ended up having outcomes that produced their first PrEP clinic that opened this year, where they partner with a community organization, NASM in Atlanta, to have them on campus every month to start providing resources around not only HIV testing, but also to bring medical providers to provide PrEP resources as well for the clinic. Next slide. And so slightly talking about our social media, part of our messaging on social media was to make sure we were disseminating a constant flow of health messaging that spoke not only about just the education of HIV, but really the education of the social determinants of health and their impact on the Black LGBT community, and also being able to weave that messaging into HIV action. And so part of our work through the last October through March of last year was we sent out 106 health messages during that time on Facebook, and then on Twitter 174. Where part of those messages were engaging Twitter chats that we had to engage around HIV prevention, HIV care, as well as addressing HIV stigma and dealing with the issues around stigma that exist in the community. And as a result of that, those messages, we were able to generate 231,000 impressions on Facebook, and then 313,000 impressions on Twitter around our health and HIV messaging. Next slide. Here we continue to, this is our web page, the landing page for our web page, where we include our blog posts, but also include resources for HIV testing, for knowledge, for testing locations on our homepage for people to be able to access when needed. Next slide. Here's another example of our blog where you can still continue to see testing resources, as well as in the bottom corner where we are intentional about, even down to our social media, about utilizing the banners and profile pictures to also continue to amplify messaging. Next slide. So here are a couple of examples of our social media messages on on Twitter during key HIV/AIDS awareness days. Being very intentional about the use of Black images, the use of diverse images representing the Black community, because we know that just using one image to represent the Black community does not do service to the diversity that exists within Black communities across the country and around the world. Next slide. Here's an example from our annual conference out on the Hill, where we ensure to include information, particularly about health and wellness, where this was our 2015, where this conference was specifically focused on our health and wellness as we were launching the Health and Wellness Initiative. And so some key things I wanted to bring to your attention as you kind of engage this audience that's really outside of public health, outside of HIV. Just as a disclosure, a lot of my work prior to working with the National Black Justice Coalition was pretty much totally within HIV, and so a lot of the work that I have been able to really learn and see is just how people outside of the constant flow of information that we get about HIV, how people are receiving information about things like PrEP that's now 5 years old, how information is being received by someone who doesn't really have a contact to HIV or public health, whether that be through a healthcare provider, a community-based organization, or a family member or school. And so we noticed comments that people were mentioning the sessions were informative about explaining the benefits of PrEP, particularly these comments coming from health services administrators not really knowing about PrEP. Also, understanding that PrEP was also a resource for women, and so being able to talk about that and being able to talk about really the usefulness of PrEP, particularly in the context of the larger Black community, and being able to support efforts that build that sense of community around PrEP adherence. And then last, we need information and access to PrEP on our campus immediately. There's not information getting on these campuses about PrEP. And so on this slide, this is part of a campaign that we started as part of our Health and Wellness Initiative called All We Need Is You. And so part of our All We Need Is You effort is to make sure that everyone understands that they have a role to play in addressing the HIV/AIDS epidemic. And so it can't just be made about Black gay men in one silo, Black trans women in one silo, Black cis women in another silo. We really have to talk about what is our role, whether we talk about a role as a mother, a role as a father, a role as a brother, sister, cousin, friend. What are those roles as people to increase information and knowledge about HIV and its impact in our communities? And specifically, how do you make sure that people who are not Black and LGBT or who are not LGBT are still championing the needs of the LGBT community within Black spaces to make sure that their needs are being met within outreach efforts? And so one of my last slides is that this is really some key lessons learned. One size does not fit all. We have to make sure that our messaging is catered to who we are seeking to reach, whether we talk about young people who are students on campus or young people who are out in clubs or older Black gay men. We really have to be speaking directly to that group and make sure that messaging is relevant and visually relevant to their needs. Communities need access to more education about the HIV/AIDS epidemic. What we are seeing on campuses, particularly out of health services and out of administration, is that there's not an awareness about where the HIV/AIDS epidemic stands here and now, and the resources that are available, like PrEP, that may not have been available 20 years ago, to help prevent the spread of additional HIV in Black communities. And then last, training is needed to empower people to engage in peer-based HIV/AIDS mobilization. We see on every level, whether we talk about student peers, whether we talk about academic colleagues, or we talk about leaders in the Black community, we need to make sure that people are engaged and are trained to speak to their peers to be able to disseminate correct, factual, science-based information to help educate about the risk of HIV if treated, or if someone, if provided PrEP, or if provided HIV treatment if positive. And so also part of our work around our Building Stronger Black Families initiative, we have worked to create a strategic platform to develop our programs that focus on removing stigma and inequalities that contribute to high rates of HIV and other disparities in Black America. And that means really utilizing the family, the Black family, however it may exist as far as blood or chosen family, to make sure that everyone is engaged about the care of their loved ones and empowered to take action to be able to be a steward of their loved one's health. And that's really the premise of our Black Families Initiative, to really build that sense of support and networking that, you know, that really already exists within Black communities. Next. And here's my contact information, and I will stop right there. And thank you so much for the opportunity to speak with you this afternoon.
Thank you, Benton. That was beautiful. That really was a beautiful presentation, and I know our audience appreciated it. Before I get to the questions, and we have a number of them, I just want to share with you, first of all, that this slides will be sent to the participants in PDF format, so you will have all this information in an email shortly, as well as the link to get your to do the test and get your CNE credit. Here are some resources that you can tap into. We have a number of resources on our website with links, and including, we'll put new links up after today to some of the resources that were listed in the presentation. Again, we talked about the CDC clinician guidelines, so there's also a link to the PrEP line where clinicians can get peer-to-peer case-based consultations. So that's one-on-one about a particular patient. There's also a PrEP locator map where you can, if you are a PrEP provider, please upload your information into that. It's a project sponsored by Emory and others, but it also, you can put your zip code in and find out the closest PrEP locator to you. And again, this is one of a series of PrEP webinars that we are sponsoring. There'll be one coming up on PrEP and women, and then another one coming up on PrEP and non-clinical settings such as substance abuse treatment centers. I now will open it up to questions, and I have a number of them. Again, many were about getting the slides. You'll get that in a PDF. The other question that was repeated a couple times is the C4 program available for wide use?
So we know that there is a need for the dissemination of the C4 client-centered care coordination model. This is a pilot. It was a small pilot. We were only given about $10 million to actually do the study. So it did not include our ability to manualize C4. And we knew that it would work, but the intricacies about how it worked is also intertwined within the qualitative data that was collected during the study, and we are still analyzing that data, more specifically led by Dr. Wilton and his team. So we are working at the moment with New York State to get some resources because myself, Dr. Wheeler, and Dr. Nelson, who was the lead C4 implementation scientist, are all in, actually, I'm sorry, even Dr. Wilton, we're all in New York State at the moment. So New York State is going to give us some pilot funds so we can manualize it. We know that we need to get this information out. All of the publications about the study are also forthcoming, and Dr. Wilton's team is going to present some of the data at the International AIDS Conference this coming summer in Paris.
Some of these other questions are probably related to C4 data, so I don't know if you can answer them with the data still pending, but I'll put them out there anyway.
Yeah.
What part of C4 was most valued?
You know, we looked at some of the early data, and honestly, it was simply the idea that these men knew that they were being heard, they were being listened to. It became a very therapeutic sort of interaction. The whole model is based on letting these men know that your life matters more to us than just a research subject. So the sense of support, the connection that was made to the study, the buy-in that they really wanted to participate, the fact that they knew the study was designed, being implemented, run by other Black MSM was also a huge factor that fed into their discussions.
Mm-hmm. Another question that's in that same vein is, do you have any information on why participants in 073 declined PrEP?
So yes, and it was important for us that we did not force people to have to take PrEP to remain in the study. There is value in people making choices, even after being educated, to not actually initiate PrEP. And what we have seen, there were some health exclusions, some prior pre-existing health conditions that prevented a small number from actually being able to. But that came up a little later. There is still some hesitation about access and, you know, the ability to keep the fact that they were taking the medication private. So the situations vary greatly. And then even not wanting, for some of the younger folks who were still on their parents' insurance and those types of things, not wanting that information to get out, even though, you know, we explained to them that in the context of the study, we would give them the medication. We wouldn't involve their insurance, but there was still that hesitation. A lot of it is still in that qualitative data that we're still analyzing.
Mm-hmm. Thank you. I'm going to switch to some of the questions about the HBCU presentation. There are other questions, and maybe we can answer those offline with the questioners if we don't have time. But here's a question: Were there any particular challenges, so Benton, this is directed to you, were there any particular challenges hosting cultural events on HBCU campuses given the taboo nature of queer or trans identities and HIV in the Black community? If yes, how were those addressed?
Well, I think that the biggest way that we addressed it is utilizing the Chapter 9 compliance officers that have to exist on institutions receiving federal funds. And so making sure that the message was made very clear that we are coming in to really help train and build compliance so that they will not end up in a situation to where they would not be in compliance because of discrimination based on discrimination that can put them in violation of Title IX. And so another piece of work that we do is really work with the administrators that we have on campus to help get us access to be able to do these trainings. And so really dealing with and utilizing just multiple stakeholders on campus that have students, but also that's inclusive of faculty and other providers of healthcare, including health services.
So there's a comment, cool, that coaches were involved. That's a comment, not a question. And another question is, besides Facebook and Twitter, is your organization utilizing other forms of social media to promote HIV awareness and prevention, such as gay apps like Grindr or Rather Jack? So are you using other mechanisms besides Facebook and Twitter?
Absolutely. We have a partnership with Grindr for Equality to push messages to all of their Black men who are users of Grindr once a month. And so we definitely work with the different applications in order to help amplify messaging.
Great. So there's a few other questions, and what I think we may do is submit those questions in writing to the panel, to the presenters, and then we can send them around to the participants as a little Q&A page, because we're at the end of our time. And I really want to thank, first of all, the members of the audience for attending and for your interest in this important topic. We as nurses clearly have a lot of work to do. We know that 94% of the students in your project then were aware of PrEP, but yet the majority could not identify a friendly provider or a place that they would go to access PrEP. And so as nurses, we have that responsibility to really make sure that that discrepancy and disparity doesn't exist. And this is part of a series that we're offering about PrEP for nurses and other providers to really increase provider capacity around PrEP. So I thank you both for assisting today and for giving your presentations and participating with us. And I thank the audience all very much. And that concludes our session for, oh, one more thing, I'm sorry. I'm supposed to put this last slide up as part of our CNE. Again, you'll get this in an email with a direct link for where you can get the CNE credit. And if you have any other questions, please feel free to connect with us at the office.
All right. Thank you for the opportunity, Carol.
Oh, you're welcome. Thank you, Sheldon.
Thank you. Have a great one.
Goodbye, everyone. This concludes our webinar.
Bye-bye.
Bye.